everybody. Recording live from somewhere. This is Zach Couples with episode number 114 of the Movement Debrief. And today, folks, we're going to get low, get low, get low, get low. As in, we're going to get into lower body tests. What is the interpretation of particular lower body tests, namely hip flexion, straight leg raise, the infrapubic angle, all types of wild and crazy stuff, because your boy Big Z has been asked a lot of questions by the people. So I need to answer a lot of questions for the people, by those people right here, fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Javier. Here's what Javier asks. Hi, Zach. Awesome job you're doing for making us better therapists. Hand on heart moment. Here's my question. How can hip flexion be limited with a narrow and wide infrasternal angle? Thank you. By the way, come to Europe with Human Matrix someday. Well, I will someday, but not any day soon because hashtag coronavirus. But let's look at hip flexion. So what's going on when you're testing someone's hip flexion? So normal circumstances, the physiological range available for hip flexion is about 120 degrees. If you can go beyond that, there has to be a relative movement occurring at the pelvis. Namely, the pelvis has to tip posteriorly. The way that the pelvis tips posteriorly is via counternutation of the sacrum. So anything that goes beyond that 120 degrees of hip flexion has to entail sacral counternutation. Now, if we look at the normal pelvic presentation of a narrow versus a wide infrasternal angle, in theory, without any other compensations, a narrow infrasternal angle should have more counternutation available at the sacrum. The reason why that is because a narrow infrasternal angle has an inhaled axial skeleton presentation. An inhaled axial skeleton presentation is equivalent to a more counternutated position at the pelvis. If you want to learn a little bit more or deep dive into that, check out the Human Matrix Foundations class. It's free. I'll link it in the show notes, which will be on zachcouples.com/lower-body-assessments at some point. So, narrow infrasternal angle, inhaled axial skeleton, more counternutated sacrum, they should have hip flexion available. Converse that with the wide infrasternal angle presentation. A wide infrasternal angle has a more exhaled axial skeleton. An exhaled position at the pelvis is more nutation of the sacrum. So the pelvis is going to be tilted more anteriorly. So what happens in this case is when that person hits that 120 degrees of hip flexion, assuming that you have a loss of movement options, they have an inability to counternutate the sacrum. So this person will not be able to compress their knee to their chest when you are testing hip flexion. So we've already explained really how one part of that side of things, i.e. someone with a wide infrasternal angle, would have a loss of hip flexion. The reason why they have a loss of hip flexion has to do with compensatory actions that are happening at the pelvis. When I go to 120, I can't go any further because that person, the wide infrasternal angle, has an inability to counternutate the sacrum. So then here's where the issue comes in. We have some people who are narrow infrasternal angle presentations who also lack hip flexion, i.e. compressing the knee to the chest. So how is it that that group of people can still have a hip flexion limitation when in theory they have a relatively more inhaled axial skeleton presentation and a counternutated sacrum? Because they should have hip flexion. The reason why these people may have lost hip flexion would have to deal with secondary compensations. So somehow, some way, the pelvis for these folks has had to orient anteriorly to match the wide infrasternal angle presentation that we talked about. It can't happen necessarily at the pelvis because this person has had that counter-nutation bias. What has to happen instead is something more superficial has had to pull the pelvis forward to create that limitation into hip flexion. You got a couple options. One option, which is your boy's specialty because he's got that crazy anterior pelvic tilt and he's narrow, would be to create a combined posterior thorax or tilt of the thorax and a subsequent anterior tilt of the pelvis by increasing the concentric activity of the back extensors. So you take a more superficial group of muscles, i.e. your erector spinae, because they roughly attach at the sacrum and they roughly attach at the mid upper thorax, and there's some attachments in the cervical spine. But if you contract that muscle and pull the two ends together, you have a muscle that has leverage to be able to push this pelvis more towards an anterior tilt or orientation. And there's also some subsequent changes that happen at the thorax. If you have this type of person who utilizes another layer of compensation, their pelvis falls into more of an anterior tilt or orientation. They lack an inability to counter-nutate the sacrum due to superficial compensation. That's one possibility. Another possibility would be to create a situation where I have increased posterior compression of the pelvis, doing a very similar action. If I compress the pelvis posteriorly by Glutemax or anything like that, that's going to shove the pelvis more into a forward position, and hip flexors will get more leverage, which will limit your ability to counter-nutate the sacrum, because if the hip flexors get leverage, that's going to pull the pelvis forward. You bring the knee up towards the chest, and because you can't overcome that tension in the front side, you lack the ability to counter-nutate the sacrum. And those would really be the instances that would signify someone having a hip flexion limitation. To summarize this great question, Javier, hip flexion limitations beyond physiological norm, i.e. knee to chest, pelvis has had to anteriorly tilt or orient in some way. For a wide, it's an easy sell because they have an exhaled axial skeleton. That leads to the sacrum being more nutated. You bring the knee up to the chest. Because they can't counter-nutate the sacrum, they lack that ability to compress the thigh to the chest. That's one instance. The other instance would be if a narrow infrasternal angle has somehow, some way, developed a relative anterior orientation or tilt of the pelvis. That could occur with a concomitant posterior tilt of the thorax, which would kick in the erector spinae to pull this thing forward. You could also have some type of posterior compressive action that shoves the pelvis more forward, giving the hip flexors leverage, which would also increase the compressive forces on the front side. Same issue. Pelvis dumps forward, you bring your knee up towards your chest, you can't counter-nutate the sacrum, thus you have a limitation in hip flexion. And those are really your options. So if you see someone and you're performing hip flexion and they can't get beyond 120, they can't compress the thigh to the chest, you know you're dealing with an inability to counter-nutate the sacrum, and you should target your interventions so that person does have the ability to counter-nutate the sacrum. Awesome question, Javier. The next question comes from the ever elusive, the ever mysterious Rusty Shackelford. Here's what Rusty asks. Hey, Big Z, a question to possibly address on a future podcast. How about now? Looking at things more through the lens of eccentric and concentric orientations. If someone is demonstrating a limited straight leg raise, what would be the likely limiting factors? In a previous life, I would describe this to patients as being limited secondary to an anteriorly tilted position, what we talked about before, causing the hamstrings to already be lengthened prior to attempting a straight leg raise or a toe touch. In this scenario, the pelvis is concentrically orienting the hip flexors and eccentrically orienting the hamstrings, which would lead me to think that they should not have a limited straight leg raise. So he's talking about if the pelvis is tilted forward, I should have enough range to have a straight leg raise. I think pelvic floor orientation could be a limiting factor, but I'm unable to visualize how. I would appreciate any thoughts you have. This is an awesome question, Rusty. I waited a really long time. Rusty asked this like aeons ago, and I waited a really long time to answer it because I really wanted to thoroughly understand this, because when he asked it too, I was like, wow, that's kind of confusing. So let me see if I can deconstruct the straight leg raise. What we have to look at when we're looking at a straight leg raise, whether it's active or passive, is what are we actually testing? And what is the position of the hip when I get into that orientation? A straight leg raise, you have a few factors at play. A normal straight leg raise, I would argue, is 90 degrees of hip flexion with the knee straight. So what we have to look at is what is the position of the bones when I achieve a 90-degree hip flexion straight leg raise. I would argue that in this position, the flexed hip is going to be moving towards more internal rotation. Let me unpack that for you wonderful people. If the knee is straight and more extended, there's this thing called the screw-home mechanism. Screw-home mechanism. With the screw-home mechanism, as the knee extends, it's not just this hinge joint. There's actually rotational influences that happen at the knee. When the knee extends, the tibia is going to be more externally rotated. Based on the relative movement of the tibia on the femur, if the tibia is more externally rotated, the femur is going to be more into a position of internal rotation. So that's point one, that's going to push the femur into internal rotation, especially as you go up to 90 degrees of hip flexion. The next factor that would go into why the femur is going to be moving towards internal rotation in the straight leg raise has to do with the terminal position of the straight leg raise. If we make the assumption that a normal straight leg raise is 90 degrees of hip flexion, in that position, muscles within the posterior hip have more of a line of pull that is biased towards internal rotation, with it being maximal somewhere between 90 and 100 degrees. The example we talk about would be your classic posterior hip capsule stretch or your posterior hip musculature stretch. We've all seen the stretch where you cross your leg like so, where, like the Taylor position stretch, like you're going to go tie your shoe, and sometimes people will pull the knee to the chest to stretch the posterior hip, predominantly the piriformis. So we've all seen this classic piriformis stretch. The piriformis in the anatomical position is an external rotator. So then why is it when we're stretching the piriformis, we pull the leg up towards our chest into external rotation? Well, I'm glad you asked. The reason why that is because in the 90-degree hip flexion position, the piriformis and a lot of the other posterior hip rotators, or the external rotators, have a change in their line of pull. In that position, they actually get leverage more towards internal rotation. And thus, that's why you would place the leg into external rotation to create the stretch. Now, when does this line of pull change? When is it that the external rotators start to move towards being internal rotators? Because at that 90 to 100 degrees of hip flexion, that's maximal. Then things change once you go beyond that. And that has to do with the line of pull of muscles such as the psoas, iliacus, lots of other wild and crazy things. Also glutemax. If you look at the research, and I will preface this, folks, the research on this is kind of lackluster. And the reason why that is because when we're talking about lines of pull and leverage of particular muscles, they're looking at things in isolation, they're looking at cadavers, and they're doing their modeling from an anatomical position. We all have different structures, and that's going to influence when these things are doing a line of pull. One, two, muscles don't act in isolation. And so even with cadavers, there's some confusion in terms of when things change. For example, if you look at Glutemax, Glutemax is the largest external rotator of the hip that we have in our body because it's big. And it's especially big if you're looking at big Z. But that muscle is an external rotator, and it externally rotates quite a bit from 0 to 90 degrees of hip flexion. But folks, no pun intended, or is it? Probably intended because it's me. I believe the research article that I read, which is this awesome thing by Newman, it's like a commentary. I will link that in the show notes because it's great. When you get the hip at about 45 degrees of hip flexion, I believe, and I might have the numbers wrong, the anterior fibers of the gluteus maximus actually start to develop a bias towards internal rotation, the anterior fibers. Moreover, there's also some research showing that that might be at 60 degrees, somewhere between 45 and 60 degrees. There's also research within this study that shows that at 60 degrees of hip flexion, the leverage between the external and internal rotators is roughly the same. So it could go either way, i.e. they both can produce the same amount of torque. My point by throwing out all of these numbers is there's some confusion in terms of when these values change, and it's likely individual. But generally, in the beginning phases of hip flexion, there's more of an external rotation bias, and towards the mid ranges of hip flexion, approaching 90 to 100 degrees of hip flexion, there's some degree of internal rotation that's occurring at the hip. So because of those factors, i.e. the screw home mechanism and the line of pull of when I get internal rotation occurring at the hip, if you can get a 90-degree straight leg raise, you likely have a decent amount of excursion into internal rotation as well as extensibility into hip flexion, i.e. the hip extensors would have to be able to eccentrically orient. Another thing you would also have to look at is on the down leg, I need to have some degree of hip extension available. If we now move to the pelvis, I have a pull into internal rotation on the flexed leg, and I have a pull into extension on the extended leg. Extension is going to bias more nutation of the sacrum, especially when I hit end ranges of extension. Internal rotation is also going to bias nutation of the sacrum. Both of those positions, when I'm hitting end range hip extension and when I'm driving into hip internal rotation, creates a relative exhaled orientation of the pelvis, albeit from varying degrees. This doesn't mean that in this test the pelvis is dumped forward, because with the relative flexion and extension there's some rotational influences. But the degrees would be I'm getting relative nutation, or I'm moving into nutation on both of these sides, with likely more nutation occurring on the extended side. When I am flexing the hip, especially as I approach complete knee to chest, the sacrum has to be able to rotate roughly to the left. In order for the sacrum to rotate to the left side of the sacrum has to be able to counter-nutate, and the right side will have to nutate to happen. This test, the straight leg raise, if I'm creating some degree of flexion at one side, there has to be some degree of counter-nutation going that direction, even though there are exhaled influences occurring on that side. The analogy I would give is I can be extending my elbow from high amounts of elbow flexion. So if I start at 120 degrees of elbow flexion, boom, and I start straightening my elbow and I stop. The movement that was happening was into elbow extension. But if you took a snapshot at what position my elbow was in this instance, it's at about 90 degrees of elbow flexion. So you can have moving towards extension but being in a flexed position. The same thing is happening at the pelvis in this straight leg raise. I can be flexing and internally rotating one hip. I could be moving towards an exhaled strategy, but I can still be in a relative inhaled position. And that's what's happening on the flexed side. If I have flexion on one side and extension on the other of the hips, the more flexed side is going to have more counter-nutation occurring on the left-hand side of the sacrum. The right-hand side, in this case, will be more nutated. That's creating a leftward rotation of the sacrum. The degree of counter-nutation that is occurring towards the flexed side is not as much as if you were doing a complete knee to chest. And the reason why that is because of the internal rotation influences that are occurring at the femur. Internal rotation of the femur is associated with more movement towards exhalation, which at the pelvis would be nutation. So you could think of it this way, is there's not as much counter-nutation with a straight leg raise as there is with maximal hip flexion. So the position of the flexed femur is going to be moving towards, but not necessarily completely in, internal rotation due to the line of pull of the posterior musculature at 90 to 100 degrees of hip flexion, one, and two, the straight knee, the knee extension, and the screw-home mechanism that's occurring at the knee, placing the tibia into more external rotation, which also creates more internal rotation at the femur. And so it's those two influences why being able to achieve a 90-degree straight leg raise signifies that you have some degree of exhalation available. With that in mind, if I need to be able to exhale the pelvis to some degree, and I need to be able to drive internal rotation at the femur, and I also have to have some degree of hip extensibility or eccentric orientation of the hip extenders, we can see now how we have potential influences locally at the pelvis that might create a limitation in a straight leg raise. If I lack internal rotation, so you have posterior compression, some way, some shape, some form. So your hip external rotators are more concentrically oriented. If you can't drive internal rotation of the femur, you're not going to be able to achieve a full straight leg raise. If I have a situation where the pelvis is dumped forward, anteriorly tilted, the femurs are going to fall into more internal rotation. So someone who has some degree of anterior tilt and subsequent femoral internal rotation, that person ought to be able to pull the leg up into 90 degrees of hip flexion or even beyond. This anterior tilt position of the pelvis is going to allow for the ability to stretch at the backside of the pelvis. What creates the limitation is if there's external rotation, concentric activity happening at the posterior pelvis, limiting your ability to get into internal rotation. The anterior tilt is only useful to some degree. Remember, as I'm moving into hip flexion, even though there is a move towards exhalation, because the hip is flexed, there has to be some degree of counter-nutation occurring at the sacrum. If I don't have that because the pelvis is way dumped forward, you could have a situation where I can't create enough sacral rotation to the left. That could lead to a limitation in a straight leg raise. In the beginning phases of hip flexion, there has to be some degree of external rotation. That's where we talked about that 0 to 60 degree of hip flexion earlier on, or 0 to 45, depending on who you're talking to. In those ranges, you have to be able to externally rotate. If I'm so far dumped forward that the femurs are biased into internal rotation, and I have a significant loss of ER, you could actually have a situation where that person has a super limited straight leg raise because those initial phases of hip flexion have to have some degree of external rotation occurring. And if you don't have that ER, you won't be able to even get into position to take advantage of the crazy amounts of internal rotation you have. Someone who's got a crazy dumped forward pelvis and the femurs fall way into IR and they don't have any ER, they can't even get into the position to appreciate the internal rotation that they have. It's not just IR. You have to be able to get through those phases of initial external rotation before you can go and recapture the internal rotation. How much do you need? Likely going to be an individual basis. More proximal influences to the straight leg raise. There's a great article that looks at suboccipital release, improving hamstring length. Doing a suboccipital release has been shown to improve the straight leg raise. So the point being is there's a lot of influences to the straight leg raise when we're talking about what we're actually looking at when we're performing this action. To summarize, straight leg raise, if you can get to 90 degrees of hip flexion, that signifies that you have some degree of internal rotation available at the hip. If you are limited, 0 to probably individualized, up to 0 to 60, but probably 0 to 45, if you can't even get into that test range, that's more of an external rotation or inhalation restriction. You need to address that first. If you can get past that and you're having a hard time getting to 90 degrees of hip flexion in the straight leg raise, since there are more internal rotation biases occurring there, you might need to drive more IR or exhalation mechanics. Both of those mechanics have influences at the pelvis because the pelvis has an inhaled strategy and an exhaled strategy, and really the entire ventral cavity, thorax, abdomen, and pelvis have inhaled and exhaled strategies. Good example would be the suboccipital release study showing an improvement in hamstring length, whatever the heck that means. So the point being is you can use the straight leg raise as a marker to see if that person in general needs more inhalation or exhalation mechanics. Super short or limited straight leg raises likely need more inhalation mechanics. To clean up that last bit of end range in your straight leg raise, likely need more exhalation mechanics to do so. The next question comes from Chris. Here's what Chris asks. How can I self-assess my infrapubic angle? Where should I literally look for my own IPA? I promise not to sue myself. Chris, that's an awesome question. What is the infrapubic angle? The infrapubic angle, if we look at the pelvis, you have the pubic symphysis, which is the cartilaginous structure that attaches the two innominate bones on the front. That is the apex of the infrapubic angle. So infra means below. If we go below the pubic symphysis, you see this V or this A shape that is the inferior pubic ramus bilaterally. This angle right here is your infrapubic angle. Now, the reason why Chris mentioned that he would not sue himself is you really can't or don't want to measure this on people because there's stuff right here, aka the goods, that if you were to touch that on someone, well, you got bigger problems than your boys got to deal with. That's not a debrief topic I'm going to touch. Now, the question is, you know, it's quarantine time and there's not a lot going on and maybe you want to measure your IPA. I'm not here to judge on what you do in your free time. You do you. The issue is with measuring the IPA is we don't have really normative data. We have sex differences. So females are going to have wider IPAs than males. So it's not really like a clear cut and dry of when we can tell if someone is narrow versus wide, because versus in the infrasternal angle, it's a little bit easier of a sell. Next follow-up, Matt, Seaman PT. Do females have wider IPA due to them having wider pelvises in general, or is it more biased towards ER in the innominates? So the reason why females would have wider infrapubic angles than males is because #babies. I need to have a wider pelvis in order to shoot the baby out. I have to be able to give birth. If a female had a narrower pelvis or had a pelvic dimensions of a male and she gets pregnant and tries to give birth, well, there could be a lot of complications because I have a structurally narrower passageway for that baby to shoot out. So, hence, that's why females generally have wider pelvises than males, structurally. I don't think that the structure of your infrapubic angle necessarily matters. The key is to have dynamic capabilities of the infrapubic angle. As I inhale, the IPA should relatively narrow, and as I exhale, the IPA should relatively wide. You could look at tests on yourself that measure your pelvis's capabilities of achieving those inhalation and exhalation positions. Gosh, if only I had just blabbed about those tests for 40 minutes. What could we look at? Oh gosh, that's right. I could look at my ability to pull my knee to my chest to assess if I have those inhalation capabilities, i.e., can my IPA narrow? I could look at a straight leg raise to see if I have some degree of my IPA to widen, i.e. exhale. There's lots of other tests that you could look at self-test wise. Can you achieve a full squat? If you can achieve a full squat without any compensatory activity, that signifies maximum capability of inhaling the pelvis. If you got a good hinge and you're not, doing the J-Lo thing, sticking your booty out, that would show that you have good exhalation strategies. How about this? If you can attain a good single leg RDL, that would show that you can exhale. If you can get a step up and go all the way up like a super high step up, that would show that you could inhale the pelvis. The general rule of thumb is if you can attain maximal hip flexion without compensation, I'm talking thigh to chest, or you can attain maximal hip extension without arching your back. If you can accomplish those things, then you likely have dynamic capabilities of your IPA, and you ain't got to put your hands down there. That's really the key. So to summarize your great question, it's not, in my opinion, useful to measure the IPA itself from a structural standpoint because there's sexual differences and we don't really have good data on what a narrow degree is or a wide degree is, like we do with the lower rib cage. That would be one thing. The key with the IPA or infrapubic angle is, can it narrow and can it widen? The narrowing of the infrapubic angle would be associated with inhaled mechanics of the pelvis. The widening of the infrapubic angle would be associated with exhalation of the pelvis. So you just need to find tests that look at that. Anything that drives thigh to chest hip flexion is a great way to assess inhalation mechanics. Anything that creates hip extension is a great way to assess end range exhalation mechanics. And if you have those capabilities, Chris, to bring your knee thigh to your chest, to bring your hip into maximal extension without any compensatory stuff happening at the ventral cavity, i.e. you having created an excessive arch or a lack of rotation or anything like that, you're probably in business. Rock on. The last question comes from Katie. Here's what Katie asks. What are the pros and cons of using an obers test instead of a standing forward flexion / Gillet test to look at SI dysfunction or pelvic rotation? For those of you who don't know what a standing forward flexion or Gillet test is, it's basically like a standing single leg stance position where you're driving the knee up into hip flexion. And what you would look at with that is you would put your hands on the PSISs and you would measure what those things do and where they move. So ideally, you would see, as you're coming up, you would see some degree of posterior rotation on the flexed leg as you are measuring this, versus an obers test, which, if you don't know what an obers test is, I have a great debrief where I talk about that. But obers test looks at a similar position in the sense that when I pull myself into position to complete an obers test, I have one hip that is extended to 0 degrees of hip extension, and the opposite hip ought to be in about 90 degrees of hip flexion. So the hip positions are the same in an obers versus a Gillet test, or a forward flexion test, or a stork test. What would be the benefits of using one versus the other? The benefit of any passive test in general is you have increased precision when it comes to being more accurate or minimizing bias with your testing. Because I can control what the body's doing, I can limit potential compensatory strategies that may happen by moving that person passively. anytime someone is moving actively, then you run into an issue where they could compensate in a wide variety of areas. So it's a lot harder to control. Now, the downside about performing passive tests is we don't necessarily know if what that passive demonstration is on the table transfers to something in everyday life. Just because someone can demonstrate a movement passively doesn't mean that they can do that actively. I could take your arms and I could move them. However, I could move them into a free throw position. And I could take your arm through the full excursion of a free throw passively. But that doesn't mean once you get on the line after I've fouled you hard that you're going to be able to complete that free throw. Now, the issue with active tests is there's a lot of other bias at play. It's a little bit harder to be objective, although is there really any objectivity in any type of test? But because there's so many other potential influences at play, the person's moving actively, you have to be able to catch things. It's harder for us to be more accurate about what that individual needs. Now, when we talk about the test in particular, the Gillet test, in order to tell what someone is doing, if we look at the test classically, i.e. using palpation to measure PSIS movement, well, palpation, folks, is not that reliable. If you look at motion palpation testing reliability at the SI joint between individuals, it's incredibly low. And even palpation within an individual is incredibly low. So we can't necessarily trust our hands in terms of what we're feeling. And so to look at what we are feeling at the pelvis when it's moving actively, where you can't constrain things as much, and then you're using your hands, which can play tricks on you, then you run into a significantly less accurate test. Now, does that mean that the Gillet test is useless? I think if we're looking at it from a palpation perspective, yeah, it's probably not the best test. But could we use a standing forward flexion or a single leg stance based position to see if someone can achieve some of the positions that we have talked about in this debrief? Absolutely. And that's where I think maybe a standing test could be useful. If I can stand and I can flex my hip and bring my knee into my chest without doing wild and crazy things at the pelvis, and I'm looking for things like, remember, 90 degrees of hip flexion, I'm going to have more IR. I might actually have some degree of opening on the pelvic outlet. If I can pay attention and see if those things are happening to some degree and they're not doing any wild compensatory things, that might be able to give you some insight in terms of what that individual might need. Because 90 degrees of hip flexion and 0 degrees of hip extension on the stance leg looks kind of similar to a straight leg raise. If a person can't attain that position without cheating, you could bet that that person probably needs more exhalation mechanics in order to attain the test position. And that might be the advantage of that. Another advantage of using a test like that could be that if you are, quarantined because of the coronavirus, well, now you have a surrogate test that could actually give you similar information to what you might get in an obers test. This is another advantage of using active testing. But I would encourage you shouldn't hang your hat on any one specific test, especially if you are using standing measures or active measures. When I'm doing my remote consultations, even though my test cluster is small, I look at several things to give me an idea in terms of if someone needs more inhalation mechanics or exhalation mechanics. And based on the cluster and enough data points, that cluster of data points lets me know if I need to perform more inhalation-based strategies with someone or exhalation-based strategies. To summarize your great question, Katie, pros and cons of active versus passive testing if we're talking about obers versus Gillet. Passive tests, you have a bit more control, you can minimize bias, but there's questionability in terms of how much it transfers towards everyday life. Also, if you're quarantined and you can't put your hands on people, it's really a no-go. Active tests. There's a lot more compensatory actions available, so it's harder to be objective when you're looking at that. but there might be better transferability when it comes to everyday life. Also, in cases of quarantine, or if you're doing remote consultations, it's a much better option than doing passive tests. Palpation, if we're talking about the Gillet in particular, is not a reliable thing to do. You can't measure with accuracy what the PSISs are doing, especially when there's only about 2 degrees of motion available at the SI joint. But what you can do is take active tests, look at what your standard is and what body positions that person needs to be able to get into when we're talking about a movement like this, i.e. if I can flex my hip at 90 degrees and I can keep the leg extended, you're looking at some degree of exhalation mechanics. But if you can take that and look at a lot of other active tests to give you data points that might let you know if someone needs more inhalation or exhalation strategies, then you're probably going to be rocking. And until you be rocking, don't come a knocking. Great question, Katie. Matt Seaman. IR and extension being paired together in gait. If someone was strong, lacked IR, and was exhalationally biased, would your thought process be on initial exercise selection? If someone has an exhalation bias, and they had inhalation restrictions, I would do things that would go towards restoring inhalation mechanics. And my general rule of thumb for most people, if you are biased more towards exhalation or inhalation, that doesn't mean that you are a black belt at that strategy. You still might need exhalation mechanics or inhalation mechanics just in more complex environments. General rule of thumb, when you're working with someone, step 1, restore normal respiratory mechanics, i.e. teach someone to stack. Step 2, drive inhalation mechanics, maximal thigh to chest compression, sacral counternutation. Step 3, drive exhalation mechanics without falling into compensation. Awesome question. Now I definitely have to wrap this up because I only got 1 minute and 38 seconds. But if you want to support your boy so I can continue to support you better, because that's what this is about, come to ZachCouples.com, subscribe to my newsletter. You'll get the access to the Human Matrix Foundations course and the Common Compensations workbook. I strongly encourage you to do that. You'll get 5 hours of talks. You'll get a free acute chronic workload calculator. Lots of good things. If you want to kick it up a notch and you want to learn even more in depth and have things personalized to you, we got some options. Human Matrix is the first option, folks. That's my seminar where we actually do a lot of hands-on work to get you to be better with your testing, 1, and 2, to coach effectively so you can apply inhalation and exhalation strategies. The next one upcoming, I haven't been advertising this as much just because who knows with coronavirus, but May 23rd and 24th, we're going to be at Dickinson College in Carlisle, Pennsylvania. June 6th and 7th, Minneapolis, Minnesota. August 1st and 2nd, Boston, Massachusetts. September 12th and 13th, Montreal, Canada. October 3rd and 4th, Ann Arbor, Michigan. November 7th and 8th, Charlotte, North Carolina. November 21st and 22nd, San Diego, California. I do have one in New Jersey and Atlanta, but these have been postponed until we iron out coronavirus. So please sign up for that. Other ways that I can help you. Movement consultations. That would be piece 1. If you're not moving as well as you'd like to, and you want to move better, or you have clients who just aren't moving as well as they could, and that's inhibiting them from their goals, whether it's walking to the mailbox, squatting heavy loads, or being able to lift your shoulder overhead without discomfort, that's where a movement consultation can help you. What that looks like is we run through my full movement evaluation virtually from the comforts of your home. #quarantine-safe. We give you some activities that will help improve your movement capabilities and get you going. I can also apply that from a fitness perspective by taking that same movement consultation and designing a fitness program. That's where online training comes into play. How would you like it if you could keep feeling good and moving good and you got exercises that are specifically designed based on what your movement limitations are? That's where online training comes into play. Definitely look up for that. Also offer mentoring. If you are needing help applying some of this stuff to your clientele and you don't know where to start, or you want to get into virtual consulting and you don't know how to best do that or coach with that, that's where the mentorship program come into play. Other places you can find me, I'm on iTunes and Stitcher for the Zach Couples Show, because guess what, folks? There's 113 other debriefs, and sometimes you might just want to listen to me. I'm also on social media, Facebook, Twitter. Those are at ZCouples. Instagram, baby, is Zach, ZAC, Couples, CUPPS. And YouTube channel is Zach Couples. You got a gang of exercises there. You'll have access to debriefs and a lot of other things. Definitely check me out on YouTube. Thank you for tuning in. You've been an amazing, sexy, and outstanding audience. I hope you stay safe during the quarantine and stay healthy. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.